Hello, my name is Dr. David Pisapia, and this is my assistant for today, a resident here at Weill Cornell, Dr. Cliff Fulmer. So today we'll be focusing on a brain cutting that is associated with an autopsy. Typically the autopsy precedes the brain cutting by about 10 to 14 days to allow adequate time for the brain to fix in formalin. So the autopsy for this patient was performed a few weeks ago. And now we'll look at the brain and then we'll submit microscopic sections and that will complete the autopsy for this patient.
Okay, so this patient was a 47-year-old woman with a medical history of hypertension, diabetes, end-stage renal disease, who was in congestive heart failure and had an arrhythmia, and she came into the hospital for placement of a automated defibrillator device and died suddenly.
Okay. And in terms of her neurological history, does she have any particular neurological history?
She does. She has a remote history of a cerebrovascular accident back in the early 2000s that left her with partial motor weakness on the right side of her body.
And do we know any details about that? Was any imaging done, for example?
We have no imaging here. There was no imaging available.
Okay. So it's always important to, if there is a neuroimaging available, to review that prior to brain cutting. So we can target our analysis if there are smaller lesions that are detected on imaging that we would then want to find in the gross specimen. With weakness on the right side, where would you be looking for a lesion in the brain?
Typically, we'd be looking for a lesion on the left side of the brain.
That's right. So when you have weakness on the right, the dominant cortical spinal tracts that are controlling your motor movement typically are from the contralateral side of the cortex. And descend through the internal capsule, down through the cerebral peduncles, and then where, if at all, do these fibers cross?
They cross in the spinal cord.
That's right. Well, so most of the cortical spinal tracts will cross actually in the junction of the medulla and the rostral spinal cord at the pyramidal decussation. There are other cortical spinal tracts which are ipsilateral, but the predominant ones are indeed will decussate at that position. So first, we're going to, before we get to the brain, actually, we'll look at the dura itself. So this is the portion of dura that was carefully dissected off by our Diener. And why don't you take a look at the dura and tell me what kinds of things that you would look for?
Sure. So first we're looking at the external surface, looking for any lesions or masses here. I don't really see anything. It looks like pretty nice, healthy dura. And
besides masses, what type of lesions are frequently associated with the dura?
You could also look for hemorrhages.
That's
the
right.
patient had a bleed, and I don't see any evidence of bleeding here.
Right. So you want to take a look at the color of the dura to see if there's any evidence of prior hemorrhage. So this is the superior aspect of the dura. You want to look for epidural hemorrhages. On the other side, you want to look for subdural hemorrhages. And if it's a remote hemorrhage, you might only see sort of a fibrous membrane associated with the subdural aspect. So in this case, the dura looks unremarkable in terms of its coloration. So we'll make a note of that. And what else do we routinely look at in the dura?
So one of the other things we look for is if there's any evidence of thrombosis in the superior sagittal sinus.
So why don't you take a look at the superior sagittal sinus? So we'll make cross sections through the superior sagittal sinus, and if other sinuses are available, we'll also cut through those, again, to look for thrombosis. Right, so the sinus looks patent. So this is just one of the routine things that we'll always check for, regardless of the clinical history. The first thing we want to do is we want to analyze the exterior surface of the brain. Typically, we'll weigh the brain before we fixed it. Do you know the weight of this brain?
Yes, it was 1,200 grams.
So 1,200 grams for a 47-year-old, is that normal?
That's about normal.
Yeah, that's about normal for that age and for that gender. Okay, so let's take a look at the exterior surface of the brain, and you can tell me what types of things we might be looking for.
Okay, so the first thing I'm looking at is just the meninges covering the surface of the brain, just to see if there's any opacities or anything that might lead you to believe there was an infection with the brain. In this case, I think the meninges are clear and pretty unremarkable.
That's right. Yeah, exactly. So you want to look at the leptomeninges. It's a thin membrane covering the brain, but when it is involved by inflammation or infection, you will see opacification. So you want to make note of that. Okay, what else would we look for?
We're just looking at the general structure of the sulci and gyri here. In this case, I don't see any signs of atrophy, but I think there's this notable finding on the left side of the brain here.
Okay, so why don't we describe this?
So there's this, it's a depression. It's slightly discolored, and I think this gyrus here is somewhat atrophied compared to the ones around it.
That's right. So if we compare to this side, for example, where we don't see the lesion, we see a nice central sulcus with the motor strip and the somatosensory strip. If we come to this side, in contrast, we can see a cystic cavitation right here. And it looks like some of this atrophy and or gliosis, which we may see, extends along the motor strip. So does this correspond, do you think, with her clinical symptoms?
Yeah, absolutely. I think this could explain the right side of weakness that she was having.
That's right. So which vascular distribution do you think this is in terms of the anterior circulation, the middle circulation, or the posterior circulation?
This should be supplied by the middle circulation.
That's right. So this distribution, you also always have to correlate with your vascular anatomy, correlates with middle cerebral artery distribution. So again, the medial aspect of the brain will be supplied by the anterior circulation, and your middle cerebral arteries, which we can see are starting in this region. Here's the internal carotid. The middle cerebral artery will go along the Sylvian fissure and then send branches along this distribution. So we want to measure this grossly from the exterior surface to have an idea of how big this infarction is, or likely infarction.
So medial to lateral is approximately 6.5
Yeah, I agree.
by 1.
1 centimeter. And so then the other dimension we'll record after we cut through the brain. Finally, in terms of analyzing the outside of the brain from the top, we want to look for evidence of herniation. So what's the herniation, the type of herniation that you would observe from this aspect?
Well, if we spread the hemispheres, we could see the cingulate gyrus.
Right.
So I could actually see down to the corpus callosum here. So I don't think there's any evidence of...
And what would the name of that? So the name of that herniation would be subfalcine herniation. All right, so now let's take a look at the ventral surface of the brain. And tell me what we need to analyze on this surface.
So here, in addition to looking at the leptomeninges, we'll also assess the vasculature of the brain here.
So what's this artery right here?
That's the basilar artery.
Right, so this is the basilar artery. So we want to take a look at the circle of Willis for evidence of atherosclerosis, evidence of what else would you look for in the circle of Willis?
You should also look for evidence of aneurysms, like a baryaneurysm involving the communicating arteries.
Right, so if you are going to have an aneurysm in the brain, frequently it will be involving the circle of Willis. More typically the anterior aspect of the circulation than the posterior. So we have to pick away at the leptomeninges here a little bit. But we can see in this region, this is actually the anterior communicating artery right here, and these are the anterior cerebral arteries. This is the internal carotid. And then to get a good look at the middle cerebral arteries, we should dissect and pull away a little bit at the Sylvian fissure to take a look at that artery. So I don't see any aneurysms. We've already documented the extent of atherosclerosis, and if you do see significant lesions, you want to take sections of that artery in that area, but we don't. The other thing you want to take a quick look at are the cranial nerves, okay? So oftentimes, if there's a cranial nerve defect, we'll have some clinical evidence of that, but we do routinely take a look at them. So here's the olfactory, right? What would this be here, Cliff?
That looks like the optic nerve.
Right, that's the optic nerve. And what is this structure?
Looks like the stalk of the pituitary.
That's right, that's the pituitary stalk. Then posterior to that, we have our mammillary bodies. And then which nerve would this be?
That looks like the oculomotor nerve.
That's right, so that's the third cranial nerve, which projects right through the superior cerebellar artery and the posterior cerebral artery, which it's doing, so it's in the right spot. This is the basilar artery. The last thing we have to do is to look for evidence of herniations on the ventral side of the brain. So which two types of herniation would we be looking for?
So we'll look up here for any signs of uncal herniation.
That's right. So you want to look in the medial aspect here of the temporal lobe. You'll see a little notch here. That's where the medial aspect of the temporal lobe rests on the tentorium cerebelli. And if there's a lot of edema in the supratentorial compartment, it can push this down, and you may see more prominent notching here, and it could potentially be more lateral. So in this case, it looks normal on both sides. So there's no evidence of uncal herniation. And then finally, what's the third type of herniation?
We'll look at the cerebellar tonsils.
Right. So if we look down here, these are the cerebellar tonsils. And again, you want to see if they're prominent, if there's a prominent notch where the foramen magnum would sit, and if they're compressing the brainstem. Okay, so now we'll go ahead and get started to cut the brain so we can look at the inside of the brain. So the first thing that we do is we'll actually detach the brainstem and cerebellum from the rest of the brain. So Dr. Fulmer. Dr. Fulmer did. So as you can see here, this is the midbrain, and we can see the pigmented nuclei here, which are the substantia nigra. Okay, so we do want to take a look at the substantia nigra, and what's a common neurodegenerative condition where you might see alterations in the substantia nigra?
So Parkinson's disease is one of the more common ones that comes to mind.
That's right. So in Parkinson's disease, one of the earlier stages of the disease, you'll see loss of pigmented neurons in the substantia nigra, and you can actually detect that grossly. Now, do we see any, now that we've cut this, do we see any abnormalities after we've removed the cerebellum?
Absolutely. So we didn't appreciate it before, but this, the area here along the occipital lobe or temporal lobe here is abnormal.
That's right. So we can see actually a large area here where the brain parenchyma looks a lot different from this side. And just externally, you can see that there's some cavitation here. There's loss of the definition of the gyri. So this actually looks like it's also potentially involved by chronic infarction. And that's actually on the contralateral side of where we saw the other infarcts. So we saw one here in the superior left hemisphere, and then we see another infarction on the right side in the inferior occipital lobe. So we'll take a look at that again, obviously, when we cut the sections, but why don't we measure this so that we have a basic idea of how large this lesion is here. So it's about 6.5 centimeters anterior to posterior, and approximately 3 centimeters medial to lateral. So again, it's important to keep looking at the brain as we go through all these steps, because you may discover things which you couldn't see before. So we'll put the cerebellum aside for now and the brainstem, and we'll proceed to cut coronal sections of the brain. So it's important to use a sharp knife for this, obviously, and I like to do this by hand. Other residents and other attendings may use sort of a cutting board device that guides the knife at different intervals, but I like to do this freehand. So the first cut that we would make is actually a cut coronally that targets the mammillary bodies. So here are the mammillary bodies, and I'll make one cut. And when you make your cut, it's important to reduce the amount of times that you're switching the direction of the blade and not apply too much pressure in a downward motion. You really want a smooth cut, like you're playing the violin, and try to only change the direction of the blade once or twice. And that way you don't have too many artifactual lines on the surface of the coronal section. So I'll make the first cut through, and you want to try to make your cut, obviously, perpendicular as possible to the axis of the brain so that you'll have a nice symmetric section. So we make our first cut like this, and you can see this is reasonably symmetric. So we've cut through an area where we can appreciate the thalamus. This is actually the mammillothalamic tract, this white matter tract. This is part of the caudate nucleus. This is the internal capsule. So this is a pretty good cut, and we can see here the anterior aspect, or the pes of the hippocampus, which is a region that we would actually want to sample, particularly in patients with neurodegenerative disease. So now we'll cut in turn each half of the brain, and of critical importance here is to keep track of the right and the left aspects of the brain. So first we'll cut the anterior half of the brain, and then we'll cut the posterior half. So now we'll proceed to make our coronal cuts. And you'll see that I'm turning the sections over so that the right is on the right and the left is on the left. Okay, so now we'll do the back half of the brain. You want to start from the ventral surface rather than the dorsal surface, because some of the more intricate structures at the ventral surface, and oftentimes the initial part of your cut is the best part of the cut. And so for these sections, we don't flip them around, and that will maintain their orientation.
Okay, so now we're going to cut the brainstem and the cerebellum here. So the first thing I'll do is make a cut to separate the brainstem from the cerebellum.
So as you cut through the cerebellar peduncles, you want to bias away from the brainstem towards the cerebellum so you preserve the brainstem structures. And the purpose of separating the brainstem from the cerebellum is that we'll be cutting the cerebellum sagittally, but we'll be cutting the brainstem axially, which we do for adults. In pediatric cases, oftentimes it makes sense to keep the two together. So why don't you go ahead and cut the cerebellum, and then we'll cut the brainstem after.
Sure.
Okay, great job. So now we're going to cut the brainstem axially rather than sagittally. And I find that oftentimes it helps to rest the brainstem on the posterior aspect, so where the fourth ventricle is, and it's easier to make it stable. If the vessels are too calcified, oftentimes I'll just remove the vessels, unless there's a particular reason I don't want to do that. But sometimes I'll just remove the vessels to get cleaner cuts to the brainstem. In this case, I think you could probably just leave them there. Okay. When you do cut it, you want to make sure that after you make your cut, you keep the left on the left and the right on the right. So just pay attention to the laterality, particularly in cases with asymmetric clinical symptoms.
Okay.
Okay, so now we've laid out the brain. We've rearranged some of the sections to make it make sense anatomically. So here we have the anterior aspect of the brain and moving posteriorly like this in columns. And again, always the left is on the left and the right is on the right. So this would be the occipital pole. And then here in this area we have the left half of the cerebellum, the right half of the cerebellum. Again, cut sagittally, and then down the middle we have axial cuts through the brainstem. So at this point we would look for any gross lesions. Obviously we already know a little bit about where to look because we saw some lesions exteriorly, so we want to correlate that. So Dr. Fulmer, could you point out where some of the lesions consistent with chronic infarction are that we saw?
Sure. So the large lesion that we saw on the anterior surface of the brain in the motor strip is this area right here.
Right.
We also have the lesion in the occipital cortex, which is in this area here. Right
on the right side. So you can see this area of retraction here and discoloration in the occipital cortex, and it extends several sections actually. So we'll want to sample that area. We will want to sample this area. And did we see any other lesions grossly in the brain?
Yes, there's also a small lacunar infarct here in the, this is the caudate nucleus.
Correct. So oftentimes, particularly in patients with hypertension and arteriosclerosis, we'll find smaller, more punctate areas of infarction that become cystic. We call these lacunar infarcts. So this is about 2 or 3 millimeters in greatest dimension. And these commonly occur in the basal ganglia where you have the lenticulostriate arteries coming off the larger caliber middle cerebral arteries. So that's a common location. So we can sample that to confirm microscopically that it is an infarction. So other than that, we took a close look before we started recording, and we don't really see many other lesions here. So at this point, we would take both our standard sections of the brain in addition to sampling specifically lesions that we grossly identify. So usually we take 10 sections of the brain, including the pituitary and the spinal cord, and we sample different areas of the cortex and non-cortical, neocortical areas. So one of the regions we always want to sample is the region of the watershed territory between the anterior and the middle cerebral arterial distributions to see evidence of hypoxic injury that might have occurred prior to death, and those are areas that have increased susceptibility to hypoxic injury. So the watershed areas between the superior gyrus and the middle gyrus, for example, in the frontal lobe, which would be between the anterior circulation and the middle circulation. So you want to sample that area and sample the sulcus, which is where the susceptibility to injury is greatest.
Sure. Thank you.
So while we're doing this, we want to, again, retain whether or not we're sampling the left or the right half of the brain. And in terms of the routine sections, it helps to just stay with one side or the other, and you can choose which side is preferable to you. And that way, if you always do it the same way, it's more routine that way. Okay, so excellent. So we've sampled the superior frontal cortex in the watershed distribution, and that will go into cassette 1. Cassette number 2, we sample the basal ganglia, and the area in particular that we target is the area that we will be able to look at the caudate, the putamen, the globus pallidus, and if possible, the nucleus bassalis. So one of the landmarks that we would look for to get a good cut, do you know the landmark that we typically look for?
Is it the anterior commissure that we look for?
That's right, it's the anterior commissure. So if we can see here, this white matter tract in this region, in the ventral aspect of the basal ganglia, is a white matter tract that crosses from one side to the other. This is the anterior commissure, and that is usually a good location to indicate where we have a nice portion of the nucleus bassalis of Maynard, which is important for neurodegenerative disease. So if you can sample an area that includes part of the caudate, this internal capsule, the putamen, the globus pallidus, and the nucleus bassalis all in one cassette, then that's ideal. So the third section that we'll take routinely is a section of the thalamus, and I usually take a section in this region, and if you can, it's good to get part of the subthalamic nucleus, and you can get part of the caudate if you can fit it. If you can't fit the caudate, that's okay because we have it in a different section. So just focus on the thalamus, the subthalamic nucleus, and you'll also see part of the substantia nigra here and the red nucleus. So all of those are critical structures and worth sampling. Because your cuts are always going to be a little bit asymmetrical, you don't have to stick with the left or the right. It's best to actually just take the section that has the most ideal cut. So it's okay to switch from left to right as long as you write it down and make a note of it. Okay, so the fourth section that we'll sample routinely is the hippocampus, and we'll select an area near the lateral geniculate nucleus for purposes of standardization across cases. So in this case, we can see the lateral geniculate nucleus right here. So this is a good cut of the hippocampus. You want to make sure that you retain the entire entorhinal cortex. So really, you should keep all of the medial structures and go as laterally as possible, and retain the lateral geniculate as well. So for the fifth section, we'll take an area in the occipital lobe, and we'll focus on striate cortex, where you see the line of Gennari in the primary visual cortex. So, for example, in this region we have the calcarean sulcus, and you'll be able to see when you can see it closer, there's actually a white line here. That's the line of Gennari. So we'll sample this area of the occipital cortex. Okay, so in our sixth cassette, we will take a section of the cerebellum, and we want to include both the cortex of the cerebellum as well as the dentate nucleus. So can you point out to me where the dentate nucleus is?
Sure, it's this nucleus right here.
Right, so it's one of the deep nuclei in the cerebellum. So when you take your section, just make sure you get both the cortex and the dentate nucleus in the same section. Okay, so now we want to take our samples of the brainstem. So we'll take the midbrain, the pons, and the medulla. Now in this case, you want to make a notch in the section to indicate either left or right, so that when it's embedded, you can be sure which side you're looking at, because these are all symmetrical sections, and we try to fit the entire piece. So give yourself some kind of a gross indication with your knife which side is left and right, and then you make a note of that.
Okay.
Great. So now let's take a section of the pons. And what you want to shoot for when you take your section of the pons is to make sure that you're getting the locus ceruleus, which are these pigmented nuclei here in the dorsal aspect of this region of the brainstem. And they're important in neurodegenerative cases, so we always target the locus ceruleus as part of our pontine section.
Okay.
Excellent. So we've taken the midbrain, we've taken the pons, now we want to take a representative section of the medulla, and we want to be sure to include the inferior olivary nucleus. Excellent. So now in cassette number 10, we'll put two things: representative sections of our spinal cord and also our pituitary gland. Now the pituitary gland will come to us in a separate cassette. This will be along with the brain in the jar that it's fixed in, and our autopsy technicians will put the pituitary in a cassette. So we just have to make a few cuts sagittally and then transfer it to our cassette number 10. So if you could make a few cuts of the pituitary gland, we'll put it in cassette number 10. Okay, so that was the pituitary gland. For the spinal cord, we already cut the dura, but you'll use a scissor to cut the dura longitudinally, and then you'll measure the spinal cord, how much has been sampled from the most rostral aspect to the conus medullaris. In this case, it was 21 centimeters. We've already measured it, and then you'll make axial cuts down the length of the spinal cord, and then analyze to see if there's any gross lesions, which we've already done, and we don't see any gross lesions in this case. So we'll just take representative sections, and we'll choose a few sections from the thoracic aspect as well as the lumbar aspect. Okay, excellent. So finally, after we've taken our routine sections, we'll take a few sections of the lesions that we see. So in this case, I would submit 3 cassettes. One cassette of the left superior infarction, one cassette of the right occipital infarction, and finally one cassette of the lacunar infarct that we see in the left caudate.
Okay.
And whenever, just like when you're grossing any other specimen, it's helpful, if possible, when you are sampling a lesion, to sample the interface of the lesion with nearby more normal looking tissue. And oftentimes it's that transition zone that can tell you a lot about the pathology. You don't necessarily want to sample just the center of a necrotic area that oftentimes will not tell you everything you need to know about the lesion microscopically. So in summary, what we've done here is first, it's important to take the clinical history into account. You certainly, in particular with regard to either neurologic history, cognitive decline, any prior history of stroke. All of these things are very important to come to brain cutting prepared with that history. And certainly if the patient has ever had any neuroimaging, to come prepared with those reports so that you can target these lesions based on the radiology. Certainly you want to try to correlate as best as possible any radiological findings with gross findings in the brain. So after examining the clinical history and the radiology, we then examine the dura, we examine the exterior surface of the brain, we examine the vasculature of the brain, and any lesions that we can identify on the exterior. Then we would proceed to detach the brainstem and cerebellum, cut the supratentorial compartment coronally. Then we detach the brainstem from the cerebellum, and we would cut the cerebellum sagittally and the brainstem axially. Then we lay out all of our sections. We look for gross lesions. We take our representative routine sections and our representative sections of any lesions that we identify. Then we will submit all of these sections for routine microscopy. And in this case, we up front will order special staining for Lux-All-Fast Blue in addition to H&E so that we can see the white matter anatomy clearly. So that concludes this brain cutting. Dr. Fulmer, you did a great job.
Thank you.
And again, whenever you have any questions during the autopsy itself, with the fresh brain in your hand, you should always feel that both Dr. Levy and myself are available to come take a look at the brain in the fresh state should you see any lesions that you want to, for example, notate in the PAD. So with that, do you have any additional questions?
I don't think so.
Okay. Well, thank you very much. It was a pleasure to demonstrate a brain cutting session.